Welcome everyone, let's dive right into this explainer. Today we're putting on our clinical detective hats to uncover the hidden dangers of pediatric urinary and bladder conditions. Because when it comes to young children, what you see isn't always what you get. And missing those really subtle clues, well, that can have lifelong consequences for a child's kidneys.
Here's our roadmap for today. We'll be moving through 5 critical areas: the hidden infection, getting the right sample, VUR, the danger highway, nighttime accidents, Enuresis, and finally, safe and effective treatment. We're keeping things tightly focused on these core issues today.
Starting things off with Section 1, the hidden infection, UTIs in young children.
Now, urinary tract infections are incredibly common, right? But the crazy thing is how differently they present depending on the age of the patient. If an older child has a UTI, they'll usually show those classic signs: painful urination, frequency, fever, or maybe flank pain. But infants under 2, they literally don't have these classic symptoms. Instead, they present with completely nonspecific findings. We're talking poor feeding, vomiting, unexplained jaundice, or even hypothermia instead of a fever. Because these clues are just so vague, you have to maintain an incredibly high index of suspicion.
So the crucial point here is that missing this invisible infection in a tiny infant can be absolutely devastating. You just cannot wait for classic symptoms to appear in a 1-month-old. If an infant comes in with unexplained irritability, poor feeding, or a fever without any clear source, a UTI absolutely must be on your radar.
Which brings us to Section 2, getting the right sample, diagnostic accuracy.
Because those infant symptoms are so tricky to spot, catching the actual culprit relies 100% on getting a perfect diagnostic sample. And let me tell you, it is so easy to get this wrong. Using improper collection methods leads to bad samples and, ultimately, misdiagnoses. One major pitfall we see all the time is relying on bagged urine specimens. These are notoriously inaccurate for diagnosing a UTI because of skin flora contamination. Another super common mistake? Forcing a child to drink a massive amount of fluid right before collection just to make them go. Why is that bad? Well, diluting the urine can actually produce a falsely low bacterial count, which totally masks a true infection.
So, we have strict diagnostic rules based on age. If you're dealing with a child under 2 years old, or really any child who isn't toilet trained, you must use suprapubic aspiration or a sterile catheterization. That is how you get an accurate, uncontaminated result. There's just no shortcut here. Now, once a child is over 2, toilet trained, and cooperative, then you can transition to a clean catch midstream sample. Nailing this diagnostic step early on is completely non-negotiable.
Moving right along to Section 3, VUR, the danger highway.
Let's look at how a seemingly simple UTI can blow up into a massive structural problem. What exactly is vesicoureteral reflux, or VUR for short? Normally, urine flows on a one-way street, from the kidneys, down the ureters, into the bladder and out. VUR is the retrograde or backward flow of urine from the bladder right back up into the ureters. In severe cases, it goes all the way up into the renal pelvis. So VUR isn't just urine flowing the wrong way. It's practically a VIP invitation for bladder bacteria to travel backward directly into the highly vulnerable kidneys.
Clinically, this is huge. It transforms a one-time, annoying lower tract bug into a dangerous, repeated route for an ascending kidney infection, which we call pyelonephritis. Instead of the bacteria being safely flushed out of the body, they're driven right up into the vital organs.
Because of this severe danger, whenever a young child has a recurrent UTI or an abnormal renal ultrasound, you have to actively look for VUR. And how do we do that? With avoiding cystourethrogram, or VCUG. This is the absolute gold standard to directly visualize if this reflux is happening while the child is actively voiding. A UTI alone doesn't diagnose VUR. You need the VCUG to actually see that backward flow on the imaging.
I really want you to walk through this chain reaction with me so you can see exactly why we care so much about catching this. It starts with Step 1, a simple lower UTI. But if VUR is present, Step 2 kicks in. The backward flow carries those bacteria upward. This inevitably leads to Step 3, pyelonephritis, a severe kidney infection that causes high fever and flank pain. If this cycle happens repeatedly, we hit Step 4, renal scarring. And here's the kicker. Step 5, that permanent renal scarring is a known cause of secondary hypertension later in childhood and can ultimately lead to chronic kidney disease. This exact chain of events is exactly why we aggressively manage recurrent UTIs in kids.
All right, Section 4, nighttime accidents, Enuresis.
Let's shift gears completely away from structural infections and talk about a functional issue. Enuresis is inappropriate urination, typically bedwetting, in a child with a developmental age of at least 5. When you're assessing a child for this, the very first thing you need to do is categorize it. Is it primary or is it secondary? Primary uresis means the child has never achieved an extended period of bladder control. Honestly, it's often just a maturational delay or tied to family history. Secondary uresis, on the other hand, means the child was successfully toilet trained, stayed dry for a solid period, and then suddenly started wetting the bed again. Distinguishing between these two is vital because secondary uresis is a major red flag. It could point to a new emotional stressor, a new medical condition like diabetes, or, connecting right back to our very first topic, a hidden UTI.
When it comes to managing enuresis, we definitely don't jump straight to meds. The very first line of defense is always behavioral conditioning. This is all about empowering the child. We use reward systems where we track dry nights on a calendar and offer positive reinforcement. We can also use retention control training, which is just having the child delay voiding during the day to help stretch their bladder capacity. Urine sensor alarms are fantastic too. They wake the child at the very first drop of moisture. But listen, the most important behavioral rule of all, never ever punish, scold, or tease the child for a wet incident. It's not intentional, and punishment only increases their stress, which actually makes the enuresis worse.
And that leads us perfectly into Section 5, safe and effective treatment. Sometimes behavioral therapies just don't cut it. When we have to turn to medication, there is a massive, non-negotiable safety rule in pediatric pharmacology that you absolutely must know regarding desmopressin, or DDAVP. It's a synthetic antidiuretic hormone used to reduce urine volume. If you are going to prescribe or administer this to a child, it must be the oral routes only. Intranasal administration is never, ever recommended for treating enuresis in children.
Why are we so strict about this? Well, we give it orally at bedtime because the intranasal route is notoriously tricky to dose accurately in kids, and it carries a severe risk of causing life-threatening hyponatremia, which is a dangerously low blood sodium level. That sudden drop in sodium can rapidly trigger seizures. It's a huge deal. So commit this to memory. Oral only. Restrict fluids for 2 hours before bed and monitor those electrolytes closely.
We've covered a ton of ground today, right? From the invisible signs of infant UTIs, the strict rules for getting a sterile sample, navigating the danger highway of VUR, all the way to the careful behavioral management of enuresis. Ultimately, pediatric genitourinary care is all about looking way past the obvious. So I want to leave you with this question to carry into your practice. Are you prepared to look closer, ask the right questions, and protect a child's kidneys for a lifetime? Thanks so much for joining me on this explainer. Keep learning, and I'll catch you on the next one.